Good morning, ladies and gentlemen, and welcome to this regional workshop on a One Health approach against antimicrobial resistance in European Union pre-accession countries. My name is Charles Price, and I'm an official at the European Commission, and I'm going to co-chair this morning's session together with my colleague from ECDC.
Good morning, I'm Dominic Mollet. I'm the head of a program on antimicrobial resistance and health-associated infections at ECDC. It's a pleasure to welcome you all here in Belgrade. As you know, ECDC, together with EFSA, spent many months organizing this meeting in close collaboration with the European Commission and WHO Europe, and it's good to finally see you here in this room.
One small piece of housekeeping before we have the formal opening of the meeting, and that is to let everybody know that the workshop is going to be filmed. That's the first part of the morning will be filmed, and there will also be sound available on the internet for people to follow it by web streaming. The main people who will be on the film will be the people presenting and the people on the podium here, and it shouldn't affect the audience, but if you do speak, your verbal contribution will be available and it will also be recorded for the future. Can I ask if that's okay with everybody, or if it is not okay with anyone, if they could make their presence known now and we can see how to manage your concerns. Good. And finally, grateful if you could all put your telephones to silent if you haven't done so already. Now, it gives me great pleasure to introduce the opening speaker, who will give some words of welcome. It is the State Secretary for Health of Serbia, which is hosting this meeting today, and I'd like you to give a warm welcome to Professor Radislav Mot Stjepanovic.
Hvala vam, uvaženo predsjedništvo, dragi gosti, koleginice i kolege. Ispred Ministarstva zdravlja želim da izrazim svoje zadovoljstvo što mogu da vam iskažem dobrodošlicu u Beograd i poželim uspešan i plodonosan rad na ovom dvodnevnom workshopu koji se bavi jednim izuzetno važnim, upornim problemom, a to su infekcije, odnosno antimikrobna rezistencija.
Distinguished Presidency, dear colleagues, distinguished guests, on behalf of the Ministry of Health of the Government of the Republic of Serbia, I wish to welcome you to this very important two-day regional workshop dedicated to a very important issue of the AMR.
Kao što sam rekao, antimikrobna rezistencija i posebno intrahospitalne infekcije koje su tema ove dvodnevne konferencije, workshopa, su problem koje je Ministarstvo zdravlja Republike Srbije prepoznalo i postavilo kao jedan od svojih prioriteta, ako ne prioritet broj jedan.
As I said, the AMR and the hospital-acquired infections, which will be the main topics of these workshops, are one of the most prominent issues that has been recognized by the ministry and given its highest priority.
Analizirajući situaciju, došli smo do zaključaka, naravno, da ovaj problem može samo da eskalira i priključili se onome što je Evropa već ranije počela da radi. Ministarstvo zdravlja je 2015. godine pristupilo nacionalnoj kampanji koja je se sastojala iz više segmenata, to je vama bolje poznato, koja je dala izuzetne rezultate.
Having analyzed the situation, we understood that the situation is bound to progress further. And 3 years ago, in accordance with the global initiatives and recommendations, our national campaign joined in, and it has given its results already.
Ono što je važno da smo mi zaista imali rezultat koji u praksi može da se meri brojem koji smo mi zadovoljni, ali ne još uvek do kraja kako smo planirali. Naime, u tom kratkom periodu, 3 godine otprilike, smanjenje, ukupna količina smanjenja upotrebe antibiotika izašla je skoro na 1/3, znači 32,8%. Uz ovo izuzetan uspeh smanjenja, što govori o racionalnoj upotrebi antibiotika u praksi, u pedijatrijskoj populaciji, tako da smo u ove 3 godine zaista uradili jedan dobar posao.
We have reached significant results in this field over the last 3 years. So we managed actually to reduce the AMR from actually up to 1/3 in the pediatric practice.
Ova nacionalna kampanja naravno sastojala se iz više segmenta. Jedan od najvažnijih je edukacija. Možda to ne izgleda posebno važno, ali kad vidite koliki je broj različitih naučnih skupova, predavanja, sastanaka održan koji su vezani za racionalnu upotrebu antibiotika, vezani za antimikrobnu rezistenciju, onda zaista možemo da kažemo da smo bili izuzetno aktivni, obuhvatili ukupan ukupnu populaciju medicinsku koja se bavi ovim poslom, ali ne samo to, nego pre svega informisanje roditelja, dece, đaka, školske populacije je dalo izuzetan rezultat.
This campaign, as you very well know, has included many segments, especially those related to educational seminars, and these included many participants, many target groups, including parents and children, and all segments of the medical staff, and has given significant results.
Uz novi nacionalni vodič dobre kliničke prakse za upotrebu antibiotika, ja bih vas podsjetio da smo počeli da radimo i na opremanju, odnosno osnaživanju, popunjavanju kapaciteta brze mikrobiološke dijagnostike i kvalitetne mikrobiološke dijagnostike s akcentom na formiranje referentnih nacionalnih laboratorija koje će zaista biti opremljene i materijalno i prostorno i kadrovski da bi mogli ovu galopirajući porast ozbiljnih i opasnih globalnih infekcija da suzbijemo na našem terenu.
In addition to the new National Good Clinical Practice Guide, which has been developed, we have also invested resources, space-wise, experts-wise, etc., in order to combat these galloping epidemics, we can say.
Ministarstvo zdravlja će i dalje ostati posvećeno podršci ovom radu, organizaciji svih ovih aktivnosti koje radimo sa našim partnerima iz ECDC i drugih organizacija vezanih za racionalnu potrošnju, antimikrobnu rezistenciju ne samo u humanoj nego i veterinarskoj medicini, sa svim onim implikacijama koje se pojavljuju u proizvodnji hrane, dakle kompletnog jednog programa koji Ministarstvo zdravlja u saradnji sa svojim partnerima sam siguran da će u budućnosti nastaviti da radi. Kamo sreće da to bude kratak period jer to bi značilo da smo postigli svoj osnovni cilj. Ja nisam optimista da ćemo naš osnovni cilj tako brzo i tako efikasno postići jer vi to znate bolje nego ja da su bakterije veštije, prilagodljivije, brže se snalaze nego što se mi snalazimo, možda zbog neke naše tromije organizacije, ali u svakom slučaju ovakvi skupovi i ovakve kampanje, ovakav rad ohrabruje, tako da kompletna podrška Ministarstva zdravlja Srbije neće izostati, ostaće kao i do sada i u to ime ja vam želim uspešan rad, napredak u ovom poslu na dobrobiti naših pacijenata i naše dece, jer trebamo da ostavimo iza sebe antibiotike koji će biti efikasni, a ne antibiotike kojima će se neke male nevidljive životinje hraniti. Želim vam srećan rad i lep boravak u Beogradu.
The Ministry of Health of the Republic of Serbia is dedicated to continue this practice of working in collaboration with the ECDC and other international organizations to combat the AMR, not only in medical practice but also in the vet medicine, through developing all the necessary workshops, and also we intend to continue with the practice. I'm not very optimistic that we will be able to overcome this hazard in the near future because, as we all know, AMR are very persistent microbes, and they actually in the future it remains for us to do our best to combat that and to leave a safe future to our children and safe antibiotics.
And welcome.
I would like to wish you
Okay,
a very successful continuation.
Yes, I wish you a very successful meeting, and I hope and we shall do everything that you feel very good in Belgrade. Thank you and good luck.
So now I would like to welcome Dr. Marit Kokki, who is the head of our international relation section at ECDC and has been preparing this workshop.
So, good morning to all of you, and very warm welcome also on behalf of ECDC. And colleagues from the Western Balkans, from the EU member states, and of course WHO and Commission, I am very happy that you have accepted the invitation and you have in fact arrived to this meeting ECDC is organizing together with EFSA in close collaboration with the Commission and WHO European Regional Office. Topic of antimicrobial resistance under One Health framework is an important one at national, EU, and global levels. It's a global threat which affects all of society and is driven by many interconnected factors. And therefore, I believe that we all agree that single, isolated interventions have limited impact, and we need coordinated action to have a real effect. Therefore, we have also chosen to bring together for the very first time the human health and animal health networks to exchange views and ideas. But on what and why? So why are we here? And I think it's good to think indeed, why are we here and what should we have with us when we leave tomorrow? So there are a variety of reasons to be together. It's nice to meet all of you and exchange ideas. And as said, the topic we have chosen for these 2 days, antimicrobial resistance, needs coordinated multi-sectoral action in the countries and with the others. The EU Action Plan on One Health on AMR, which we will hear more soon, provides a framework for One Health actions. And another framework which I would like to spend a few more words on is the Western Balkans strategy of the European Union, a credible enlargement perspective for an enhanced EU engagement with the Western Balkans. And I think there are some important messages for all of us. This provides a key driver for transformation, and that transformation enhances our collective integration and security, among other things. But credible enlargement needs also credible efforts and reforms. And I think antimicrobial resistance is an excellent area for this, as it would very nicely fit into several, at least 2, of the flagship initiatives in social inclusion and digital agenda. And we know also that one of the reasons to be here is that regional cooperation is essential. And we know it also from the member states' perspective that both are needed, working alone in the country, but also working together and learning from each other. So, the first time we met on AMR was in 2012 in Croatia. And in that meeting, we took a snapshot of the situation and what was the situation at that time. And when looking back, the advancement has been fragmented, and of course there are countries who have taken big steps forward and some less. And therefore we thought that it's time to explore a bit deeper what are the commonalities in the region which could be addressed together, and also during these 2 days to come up with ideas which would also be taken forward nationally or bilaterally with others. So all of these actions are important, but to have a visible, credible and sustainable outcome, I think we need each other. This said, I wish that through interesting, enlightening discussions today from country perspective and tomorrow from regional perspective on the future actions needed on AMR at national and regional level, we would have crystallized ideas so that we could tomorrow, before we leave, also talk a little bit about future. So with this, I welcome once again all of you, and I look very much forward to our discussions and conclusions. So very warm welcome.
I would now like to introduce our colleague Pierre-Alexandre Belloy, who is an expert in antimicrobial resistance surveillance in the biocontamination unit at the European Food Safety Authority, EFSA, and EFSA has been co-organizing this meeting with ECDC.
Thank you, Dominic. Yeah, it's my real privilege and pleasure to welcome you here today on behalf of EFSA. It's an ECDC and EFSA workshop, and we are effectively delighted to have you coming from both sectors, public health and veterinary public health sectors, to exchange views and ideas on how to deal with the threat of AMR. For EFSA, foodborne AMR is a key topic, and through various scientific opinions and reports on AMR, EFSA has given to the member states, to the European member states and to the European Commission risk evaluations, advice on potential control options, and managerial recommendations on AMR monitoring as the basis for policy planning with a One Health approach. One Health is a key concept here. And this support allows the European Commission and in advancing on the development of the 2017 action plan, and as well support the member states in implementing their own control programs against AMR within this perspective of the action plan of the Commission. And indeed, it is my pleasure to wish you an excellent workshop today, a fruitful meeting, and interesting exchange of views and experience about AMR in the EU and in the Western Balkans. Thank you very much.
I will now hand over to the European Commission. Charles.
Thank you very much, Dominic. And on behalf of the European Commission, I really would like to thank the organisers, that's ECDC and EFSA, and the Republic of Serbia, for convening this important meeting. The Commission's really concerned about antimicrobial resistance, and we very much wish to work with partners in pre-accession countries and with our other partners, such as WHO, who's here today, to try to assist you to make a transformation, really, in the way that we approach the use of antibiotics and the prevention of infection in both the human and animal fields in order to tackle this great problem. Now, I'm going to say a few words about the Commission's role in this and the European Action Plan on Antimicrobial Resistance. And although, as you see at that last line at the end, there's a 2017 European One Health Action Plan against antimicrobial resistance, it's actually built upon more than 20 years of work. And it was back in the end of the last century that we began to realize that resistant infections were becoming an increasingly important problem which starting to threaten not only our public health, but our health systems. And there were three aspects of that, I think, that were recognized by the Commission then. The first is the size of the threat and the potential threat. The second is that in order to tackle it, we had to work in a One Health approach, both in the agriculture and livestock and veterinary sector and in the human sector, because the threat is driven by the inappropriate use of antibiotics wherever that takes place. And thirdly, we recognise that resistant organisms cross borders, they cross with people, they cross when patients are transferred, they cross when animals move and when food is sold, and that we need to cooperate together internationally to tackle this issue, both because of its nature as a public health problem, but also because the history of the European Union and the European community shows how cooperation adds value to what you can do locally in terms of learning, in terms of methods, in terms of not reinventing the wheel, in terms of common approaches. So we started first with trying to characterize what's the problem and a European surveillance system and putting in place some common standards for measuring what it meant to be antimicrobial resistant infection. Member states then passed a number of key recommendations for themselves on what was prudent use in human health, how to tackle patient safety, including prevention of healthcare-associated infections. And in 2011, we had the first action plan, which said that we needed action in the human health sector, the veterinary sector, and in research that was to tackle this issue. And we revisited that in 2017 with the new action plan. But we'd already, I think, achieved a number of key things. We'd already established surveillance systems in both the animal and human health field. We'd already got a common understanding amongst our member states that antibiotics should not be used as growth promoters, and indeed that was reinforced with a ban on use of antibiotics in growth promotion, the first across the world. And we produced, I think, a strong consensus on what was good practice. What we hadn't done, though, is really achieve the transformations which are needed in the agriculture and human health sector. And then in 2014, we realised that we could potentially be on the cusp, on the beginning of a disaster. These figures, which come from the O'Neill report from the UK, which predicted that by 2050 we could be looking at 10 million deaths a year from resistant infections. That analysis was supported by analysis from the World Bank, which added that we could be looking at between 1 and even 5% of GDP impacted. That's trillions of euros or dinars or dollars. And that AMR, in the words of the World Health Organization, was a slow tsunami which was some way off, but unless we started to run now and protect ourselves and tackle ourselves, it was going to overcome us. And in the words of the European Commission's Chief of Health, the AMR is a ticking bomb, one of the greatest challenges facing mankind today and a key priority of my mandate. So, under the leadership of Vytenis Andriukaitis, we put together the new EU AMR action plan, and it's got a number of key differences from the previous ones. The first, it's got an emphasis on making the EU a best practice region worldwide, and in order to do that, it's got a strong emphasis on how to support member states and partners to upgrade their practice and become the best. We already have some member states who are among the best in the world. We need all of them. The second was on boosting research and development, not only on new antibiotics, but also on diagnostics, on vaccines, and also on other action needed to tackle AMR. And the third was on shaping the global agenda, because we know that we have to work globally, we have to work with our partners wherever they are, and of course, we have to work most closely with our partners in our neighbourhood and in our pre-accession countries in order that we can start to produce the kind of momentum for change both locally and internationally which will head off this problem. Here are the levels of action. And I put the EU in the smallest letters, because although the EU's, we hope, and the Commission hopes, we've got an important contribution to make, we have to be realistic. The action really needs to take place in member states, and even more so at the local level in hospitals, farms, clinics, laboratories, and it needs to engage the individuals, the people, the professionals on the ground. And the EU has got some important tools, but nothing will happen. Believe me, virtually nothing can happen without the total commitment from you driving change in member states. Here are some of the tools that we have. We can have high-level meetings, political meetings, and these are incredibly important to get the commitment from ministers. But it's not enough. We can make laws and we can make regulations which can apply to member states, but it's not enough unless those are followed and internalised and used to try change. And we can provide some coordination, meetings, discussions like we have today, and we can provide some resources. I think sometimes we look at the EU's resources, we think how vast they are. €1 billion. That's €2 per citizen, folks. It doesn't go very far once it's spread over 500 million people. And we have enormous advantage of the technical assistance provided by colleagues in our European agencies, staffed by staff from all over the Union. So, we're going to gallop now through some of the EU actions. But first of all, on the law. There's a very small amount of law on the human health side which is relevant here. The first one is the Serious Cross-Border Health Threats decision, which is about how member states agree to cooperate and also agree to carry out surveillance. And then there are procedures for how to do that surveillance, definitions, which are regularly updated. There's much more law, of course, on the veterinary side, and I won't try and describe it all, but just mention the latest veterinary medicines regulation, which includes the power to reserve some antibiotics for human use only, but it also applies to other fields, such as the Water Framework Directive, for example, which will now require monitoring of antibiotics in the environment. On the coordination and side, we've got a Health Security Committee with people like yourselves meeting either by teleconference or physically to discuss how to tackle cross-border threats, including AMR. There it is. It shares information and it coordinates planning, alert and response. And it has its own system for the early warning and response system, which in the last year or so has been triggered, I think, on about 4 occasions for serious resistant threats, whether that be multi-resistant gonorrhea infection, carbapenem-resistant antibacteriaceae being transferred from hospital to hospital within the Union, MDR-TB clusters similarly, or indeed the threat that's being noticed from Candida auris, which is prevalent in 2 countries and in a number of other countries outside the Union. What about funding? I mentioned there's the health programme, which can fund some public health activities. We've got, of course, an enormous research programme. I'll mention that in a minute. Structural funds for those which are members of the EU, and the enlargement funds, which we're going to focus on in particular tomorrow. I think the key thing of all these funds is that they are driven by member states' needs. The EU does not come and give money for a particular topic and say, you go and here's some money, go and sort out this problem. No. Member states, first of all, have to define what they want the money for in the programs and then ask for the money. So it requires prioritization at national level. It requires people to put the case forward at national level. So on the structural funds, although there's potentially large sums available for health, many member states have not chosen to use them. And only 2 or 3 have chosen to use them for AMR. And a similar thing will apply to the enlargement funds. It'll be up to you and your countries to decide if they want to use them on transforming health services to tackle AMR. And it'll be up to you to decide how practically to use them. And if because, of course, there's a lot of competition and a lot of other areas of the EU's acquis law that they potentially could be used for. We partly pay for a joint action on AMR together with our member states and more than 40 partners to help support learning on the development of national action plans and also on strategies for healthcare-associated infection. We've launched a major program of training, and for those of you who don't know, that's also available to all of you to participate, both from the agriculture and human sector. And if you want further information on it, I can put you in contact with the focal point afterwards. We fund a certain number of EU reference laboratories in the veterinary sector, and we fund reference activities through ECDC in the human sector, but not actual direct funding. We look at antibiotic awareness. Here's a survey of 27,000 EU citizens, which we did last year. With some encouraging results, there's been a small decline of people reporting taking antibiotics, but still we have more than 20% of the antibiotics taken for flu or colds. Very briefly on the EU agencies, because you're going to hear a lot about that in a minute. Firstly, they're not in isolation. We collaborate incredibly closely between the Commission and the agencies. And here's one example of the EU guidelines on prudent use of antibiotics in human health, which are available in 23 languages. So we're not yet available in the national languages of any of the countries here, but that could be happened. And there are other languages which you might find more readable than English on the internet. We do One Health visits to member states. We've done at their request to look at what they're doing on AMR and provide advice both on the human and veterinary side. We're going to hear from Dominic in a minute about the supporting and the results. But I think one message that the Commission is taking away is the enormous diversity across the EU in where the problem is. That's the red countries on these maps. And you can see that Southeast Europe unfortunately, is one of the hot spots for resistant infection. And clearly, it's a very important issue for you in terms of why it should be a priority when you're transferring patients. We know where you're getting input from Italy, from neighbouring countries in the Balkans, that you need to both strengthen your own abilities nationally to detect and contain resistant infections, but also enhance, we think, your ability to work together and together in the region to tackle the issue. And a second big thing that we've taken away from ECDC and OECD's work is the burden of mortality. Over 100 Europeans are dying every day from resistant infections around. But there's a very big difference. Some countries have more or less got very low, have more or less cracked the problem and got very low mortality from these infections, and others, it's the opposite. So I should just move swiftly on and mention that we also have, in addition to the things that we're doing together within the EU and within the countries together, we also have very important international partnerships. And one I want to mention, because Danilo Lowerfong's here, is our collaboration with the European Union, with the European Office of WHO on supporting member states. And of course that includes the accession countries in this respect in work on AMR, and hopefully he will mention some of that action when he speaks. But we're also working in other regions of the world with WHO on raising awareness and also exchange of information on how to tackle it. And the second very important partner is the Organization for Economic Cooperation and Development, which has produced this analysis, which I commend to you, on the cost effectiveness of interventions, essentially saying that we could reduce the death rate by over half at the cost of around $2 per person per year. And by the way, most of that money would be recouped by the health system within a year after the investment. I mentioned briefly the Horizon 2020 and the research programme, to say we spent over €1 billion on research in the last 5 years, and as we're coming towards the assessment of where we are, we do have a number of new products in the pipeline, both new diagnostics, potentially new antibiotics, and also some encouraging vaccine development. We in the EU are focusing very much now on some upcoming events. At the end of this week, the Romanian presidency will host a ministerial meeting on AMR, and that meeting will take stock of where we've got to over the last 2 years and will help to put forward some recommendations, the so-called council conclusions, on antimicrobial resistance and healthcare-associated infection, which will be adopted by ministers, and with action points both for countries and for the Commission that they wish to see followed in the coming period. So we're very much looking forward to this new assessment there's going to be, and potentially new guidance about what we're going to do. There's going to be a global AMR conference in the Netherlands coming up in June, which will perform, I think, a similar function for the Global Action Plan on AMR, which was adopted in 2015, and now we're about 2.5 years into, 5 years, sorry, into that, and look for where we're going to go on that in the future. And we will be doing a similar workshop to this one for our neighbourhood countries. That's both in the east side and also in the southern neighbourhood later on this year. Now, I was asked to say what the state of play is, and I just decided to choose just 2 or 3 of the, I think, key outcome indicators here of what's happened in the last 5 years or so to these really on the ground. And I think the first is the good news, is that finally we're seeing in the EU a fall in the sales and indeed on corresponding use of antibiotics in the veterinary sector. You'll hear more about that later. Less good news is that in the human sector, although we've seen a small fall, it's really very small. And bearing in mind that we've got a 3 to 4-fold variation between the lowest use countries and the highest use, there's clearly a lot of potential for reducing use or inappropriate use in the health sector. And the most worrying of all, we're seeing a continued rise in death and disability, the latest from AMR. It's not strictly comparable. The figures from 2017 were 33,000 deaths in the EU EEA from AMR compared to the 2007 data of 25,000. So that's by itself more than 20% increase. It's nearly 25% increase. But when you actually take into account that there are differences in methodologies between these two analyses, actually the increase would be much greater. And the forecast is for worse to come. And that's the bad news. But the final point of good news, though, is that I think we're seeing, and this meeting that we're having today is evidence of that, an increased level of awareness, an increased level of attention, an increased action at all levels. I think if we can continue that momentum over the next 5 to 10 years, utilising all the resources that we have at our disposal, there's every reason that we know now what to do to get this under control and could achieve it. Thank you very much.
Thank you, Charles. We have time for immediate questions, if some of you have questions. We'll have also time for discussion at the end of the series of presentations for this first part of the morning. But thank you very much, Charles, for a broad overview of everything that has been done the past years. If no question, then I suggest that we move immediately to our next session on AMR and antimicrobial consumption in humans, animals, and food at EU level, which is a review of the functioning and the data from the various surveillance systems that are in place in the EU in all of these sectors. And the first presentation will be by my colleague Tommy Shetke, who's an expert in antimicrobial resistance and healthcare associated infection surveillance at ECDC. And he will present the system that we have for surveillance of AMR and antimicrobial consumption in humans for the EU and EEA countries.
Thank you, and thank you for the opportunity to present these surveillance systems in EU in this nice workshop. So I'll be briefly describing the surveillance of antimicrobial resistance and antimicrobial consumption in humans in the EU EEA. And starting with the surveillance of antimicrobial resistance. And this is a presentation drafted with the support of several colleagues at ECDC, including Dominic and other people. So, surveillance of antimicrobial resistance in European Union and EEA is coordinated by EARSnet, that is based on a network of clinical microbiological laboratories in Europe, which collect routine antimicrobial resistance data from invasive isolates, thus from blood and cerebrospinal fluid. And the laboratories participating, they are selected by national focal points, nominated contacts, with a goal to provide representative resistance data for each country. The surveillance includes 8 bacteria of significant public health importance for Europe. You can see them in the timeline in the bottom of the slide. The surveillance started with Staphylococcus aureus and Streptococcus pneumoniae over 20 years ago, and then other microorganisms were added as time went along. The last addition was Acinetobacter species in 2013 to EARSnet surveillance. And the surveillance contains over 30 bacterium antimicrobial group combinations for under the regular surveillance, so different antimicrobials for each bacterium. The production and delivery of outputs of EARSnet follows a certain annual cycle, starting from the reporting protocol updates early in the year, the data call in the spring, summer, data validation in the summer period, analysis in early autumn, and then first data publication and transferring the data to WHO in October, and finally publishing the report during European Antibiotic Awareness Day in around 18th November each year. ECDC then provides support to member states to ensure high data quality and the sustainability of the network, including annual external quality assessments of the laboratories to provide comparable antimicrobial susceptibility testing data and to have transparent data quality standards. And in 2018, a large part of the laboratories participated to this exercise, and the EQA report is published annually. Then, as mentioned, every beginning of each year, the detailed protocol and analysis plan is updated, and it includes data cleaning and analysis patterns and a protocol for these things. There's also the WHONET software that is used by 2/3 of the EU EEA countries that facilitates the data collection and data management from the laboratory level to the national level and then to the EARSnet. And then in the summer, after the data call and during the data collection, there is an aim to have fast feedback to countries from ECDC for the detection of errors and rapid correction of possible mistakes. So looking at the quality and comparability of the country data in EARSnet, there are 30 EU EEA countries participating annually, and so reporting is timely and quite complete. And there's a continuously increasing number of laboratories and reported isolates. So from 2010 to 2017, we see that the number of reported isolates have doubled to EARSnet. And we also see that there's a continuously increasing implementation of the UCAST clinical guidelines in EARSnet surveillance from 2010 to 2017. The green part is the isolates using the UCAST guidelines, laboratories using them. And 90% of the EU EEA countries rated their data as representative for their population, so the overall representativeness for EU EEA is very good. And in 2018 there have been further attempts to do more data collection to even better capture the data quality and comparability. The routine outputs of EARSnet include the annual surveillance report that is, as mentioned, published for the EAAD in November. It includes trends and data for the last 4 years, and also country summaries for each participating country. The EARSnet data is also reported to the ECDC Surveillance Atlas of Infectious Diseases, which allows exploring data from 2000 to 2017 currently. It allows seeing the data with age and sex distribution, of course, for each bacterium antimicrobial combination, and it allows exporting the data in different ways. And in between 2009 and 2016, there have been over 1,200 citations on EARSnet data in scientific literature. The country summary sheets, which are included in the report, were added relatively recently. They provide country-specific information on data quality and comparability, and allow the comparison of antimicrobial resistance percentages with the EU EEA population-weighted mean for certain key bacterium antimicrobial group combinations. And looking a bit in the results of the EARSnet surveillance, here we see from 1999 to 2016 the E. coli with resistance to third-generation cephalosporins. And in the first years, in the upper left corner, we see that first more and more countries started to report, but the map was relatively green, which in this case means a green traffic light and a relatively good situation. And slowly across the years to the bottom right corner, we see that the whole of Europe is transforming more and more yellow and then more and more orange, which means higher proportions of resistance seen in EARSnet. And when expanding to the data from the WHO Europe and the CESAR network for 2017, where we see partially the same data for the EU EEA countries and then data for several countries that are also present in this meeting. So this is from the CESAR report published in 2018. And beyond routine surveillance outputs, EARSnet then contributes to the CHIACRA, the One Health report. CHIACRA is the ECDC EMA EFSA joint interagency report on antimicrobial resistance and consumption. And also there was the AMR burden analysis published in 2018 that Charles mentioned in his presentation. And then ESNet also contributes data to the GLASS Global Antimicrobial Resistance Surveillance System. And then moving to the second part, which is the surveillance of antimicrobial consumption in EU, EEA. The network is called ESACnet, and it started as an EU project in 2001, and then since 2011 has been coordinated at ECDC. All the 30 EU EEA countries are participating, and it collects consumption data on ATC groups for systemic use. The reporting is done either on community and hospital sector, depending a bit which data is received from each country. The data sources are sales or reimbursement, or in some countries both. And the main indicator that is reported is the defined daily doses per 1,000 inhabitants per day, which is a measure that allows somewhat more robust comparison between population groups and between countries. And the objective of ESACnet is to allow public access to EU EEA reference data for monitoring the progress on prudent use of antimicrobials. A bit similarly as for the ESNet, the life cycle of the report starts with the reporting protocol early in the year, data call in the spring, validation of the data and analysis in the summer or early autumn, and publication of the results for EAAD in November. And in 2018, these new validation steps were also added for ESACnet. The outputs with public access from ESACnet include the annual epidemiological reports of ECDC, published for ESACnet data since 2012, and the last one for 2017 data. Then EAAD summaries for November. Then the annual surveillance report that was published last time for the 2014 data and has partially been replaced by the annual epidemiological report. And then the protocol, as mentioned, published early in the year and updated, containing all the changes, for example, to the DDD definitions. And for ESACnet, there is also data available from an interactive database for all countries from 1997 to 2017, including then 7 different reports and country sheets from different aspects of antimicrobial consumption, and providing these indicator results, the defined daily doses, from different points of view. And for example, for November 2018, so reporting 2017 data, the overall EU EEA average defined daily dose per 1,000 inhabitants per day in community for antibacterials for systemic use, it was about 22 DDDs, which translates approximately to 1 antibiotic course per EU citizen per year. And there we see that in 2013, 2017, there was an extremely slight decrease, so we can say that there was no increase, but there was not really a significant decrease either, so we can just say that it was relatively stable. And as was mentioned in the previous talk as well, there was a large variation between the EU EEA countries. In the community, the DDDs varying from 10 to over 30, so a 3-fold difference. And similarly, in hospital sector, the EU EEA average was 2.0, and the country variation from about 1 to 3.1, so a 3-fold variation there as well. And looking a bit on the map, looking on the left side, we see a European map on the consumption in defined daily doses. So the same numbers as I mentioned, a large variation between countries, redder and darker meaning higher consumption. And then in the right side table, we see from the hospital sector the consumption of carbapenems in hospitals. And also there we see an extremely large variation between EU EEA countries and increasing trends in the consumption of carbapenems in about 9 countries, and then decreasing trend in 1 or 2, maybe 3 countries. And when extending also this to the WHO Europe data collection, which follows the same, which has a protocol based on the ESACnet protocol, so the data is comparable. So here we see then even larger variation from 10 to over 40 DDDs per 1,000 inhabitants per day, and also there's data from many countries that are present in this workshop, and you have most certainly seen these results before. And similarly as EARSnet, also ESACnet provides then data beyond the routine surveillance outputs, again to this joint interagency report on resistance and consumption. and to GLASS, the Global Antimicrobial Resistance Surveillance System and the Global Antimicrobial Consumption System, and then also for scientific outputs such as long-term trends and further analysis on reserve antibiotics. Thank you.
Sorry, we have time for a few questions. If you have immediate questions on this data, we made an effort to show you, try to put your data next to the data from the EU and the EEA countries. Well, if no questions, you want to say something? No? Okay. So could you show the slide with antibody consumption, with the comparison with?
Can we have the presentation back for a second, please?
And my question to you is, have you seen this data presented this way before? And the differences between your countries, the countries of these regions of the Western Balkans, with some having very low antibiotic use, and here it's antibiotic use combined for the community and the hospital sector, and other countries in this region having a much higher antibiotic consumption. It's something to keep in mind for the discussions that we will have in the working groups tomorrow. And the same for antibiotic resistance. I can already make an announcement that we are now, I've made a commitment to work closely with our colleagues from WHO Europe and CSER to, at some point in 2020, produce one single report with the data combined. We are thinking about doing the same for antimicrobial consumption, although we're less advanced, but I'm sure it will happen at some point. If no immediate questions, then let's move to a similar presentation, but focusing on antimicrobial resistance from EFSA on monitoring and epidemiology of antimicrobial resistance in food-producing animals and food in EU EEA countries.
Thank you, Dominique. Okay, yeah. Sorry. So the intention is to provide a quick overview, both on the monitoring of resistance in food-producing animals and food in the EU, and as well provide or convey a number of key ideas or concepts, both on monitoring and on the situation on AMR. So in the EU, the monitoring of resistance, antimicrobial resistance in food-producing animals and food is mandatory. And the legal basis is a Commission implementing decision deriving from a directive to 2003/99, which is called the Zoonosis Directive, and which foresee mandatory monitoring of zoonotic agents and as well antimicrobial resistance in both zoonotic agents and indicator bacteria. The technical requirements of that legislation are underpinned by technical specifications issued by EFSA. And this monitoring, which is currently covering the period 2014 up to 2020, is implemented by the member states within the framework of the 2011, the first action plan from the Commission. Of course, there is as well a technical support, very important technical support provided by the EU reference laboratory on AMR, but I will come back on this later. So this monitoring of AMR in food processing animals and food is mandatory. The objectives are rather clear. First, to identify emerging resistance patterns, to monitor and assess temporal trends, and to contribute assessing the impact of antimicrobial use on antimicrobial resistance. This is the aspect of the GYROCRA project. As well, the objective is to fuel risk assessment with data, and as well, from a risk managerial perspective, to plan targeted interventions and to measure the effect of such interventions. And of course, the reduction of use of antimicrobials in animals is a very important intervention. So the monitoring is fully harmonized through the legislation and through technical specifications issued by EFSA. Monitoring is performed in foodborne zoonotic Salmonella and Campylobacter jejuni, as well as indicator E. coli. And the monitoring has been broadened by monitoring specifically ESBL and MC carbapenemase producers in E. coli and Salmonella. The monitoring is performed in the main food-producing animal populations on a rotating basis. Every second year, the monitoring is performed in poultry, considering separately different poultry populations, laying hens, broilers, turkeys, fattening turkeys, because of course the factors responsible of the levels of resistance may vary importantly between these different animal populations. So it fully makes sense to monitor at the population level and not at the animal species level. And every odd years, we monitor resistance in fattening pigs and calves, veal calves, so bovine animals under 1 year of age. Technically, the monitoring is completely harmonized using phenotypic susceptibility testing, microdilution. The set of substances tested is harmonized, as well as the dilution ranges. Resistance is interpreted using ECOFs, UCAST ECOFs, and so microbiological resistance is monitored. But the dilution ranges encompass both ECOFs and clinical breakpoints, and we can as well monitor clinical resistance levels where necessary. But the philosophy is to monitor microbiological resistance in order to detect as soon as possible a phenomenon, new phenomenon, or evolutions. And as well, what is harmonized is the representative sampling designs, not only the laboratory methods to assess resistance, but as well the sampling and the representativeness of the data collected. So as said before, the EU reference laboratory on AMR, appointed by the European Commission, which is currently Danish Technical University based in Copenhagen, provide a very important support to the member states, to EFSA, to the Commission. And this support is crucial to enhance harmonization of monitoring and comparability of reported data, comparability and reliability of reported data. So EURL has provided harmonized protocols, provide regular trainings about laboratory methods, as well as PT trials on a yearly basis. And there is a kind of cascade. The URL provides support to the NRLs at the member state level, and NRLs should support field laboratories involved in the AMR monitoring. So as well, the monitoring is based on randomized sampling strategies. There is the strategy is the stratified sampling with proportional allocation. It's a unique approach of stratified sampling, either collecting cecal samples at slaughterhouse or meat samples at retail. So it's a choice which has been made to provide a kind of unique approach in order to facilitate the implementation by the member states. So EFSA provide support to the member states and trainings as well, both regarding the implementation of the randomized sampling strategies and as well regarding the data collection in order to harmonize the reporting and as well to share experience in the implementation of the monitoring systems of AMR in food-producing animals and food. The main recommendations are to process step by step and clearly to identify data sources, data providers, and to establish good collaboration between the samplers, the laboratories, the reporting officers, so typically the competent authorities, in order to smoothen the system and to report good quality data. So in terms of result, we can only show some of those results that we're able to collect, to collect through the harmonized monitoring. And we can focus in particular on data deriving from commensal indicator E. coli. We will illustrate with the most recent data deriving from the year 2017, so from pigs and calves, and we will put in parallel data obtained in poultry in 2016. So the report on the year 2017 will be published, should be published later today. So here we see, considering three antimicrobial substances, ampicillins, sulfomethoxazole, and tetracyclines, which are typically used in veterinary medicine, in poultry and in pigs, that we have rather high level of resistance to these commonly used antimicrobials in veterinary medicine. The stars show the assessment of the situation at the EU level, while the bars exemplify, the marked variability between the reporting member states. And this important variability is to be noticed. If we consider levels of resistance to the so-called critically important antimicrobials in human medicine, so fluoroquinolones and third-generation cephalosporins, considering level of resistance to ciprofloxacin and cefotaxime, clearly we can see that we have high level of resistance to fluoroquinolones in poultry, much lower level in pigs and calves. And if you consider the level of resistance to a third-generation cephalosporin, cefotaxime, on the right-hand side of the graph, we have very low level of resistance. And in the middle of the graph, we have constructed levels of combined resistance to those critically important antimicrobials, so levels of rates of isolates exhibiting combined resistance to ciprofloxacin and cefotaxime, both using ECOFs and clinical breakpoints. So levels of combined resistance is rather low. What we can notice still is that we have outliers. So in some member states, this combined level of resistance may be rather high. Another interesting indicator, which we have started to set up in the EU summary report, is what we call the level of complete susceptibility in indicator E. coli. So the definition of complete susceptibility is given within the framework of the harmonized monitoring. So the proportion of indicator E. coli exhibiting susceptibility to all the classes covered by the harmonized set of substances monitored. And here we can show through these maps, first, that the map is fully populated. So this is one of an important objective, that the monitoring has been implemented by all the member states. And as well, what we can see clearly is a north-south gradient. These maps show complete susceptibility in indicator E. coli from pigs. We can, of course, construct some similar indicators in broilers, in turkeys, and in calves, and we can construct what we call an overall indicator of complete susceptibility, covering all the main food-producing animal populations. So, and we can compare those data on complete susceptibility with the overall consumption of antimicrobials, and considering the same sets of substances or antimicrobial classes. And that's what we did within the framework of the joint project GIAGRA with ECDC and EMA. And when we do this comparison, clearly we saw a link, an association, which is statistically significantly negative, meaning higher is the level of consumption of antimicrobials, lower is the chance to pick up a fully susceptible isolates. And because of the variability still observed in both the scale of overall consumption of antimicrobials and the scale of complete susceptibility, this complete susceptibility is an interesting indicator. And as well within the framework of scientific opinion produced in collaboration with between EFSA, ECDC, and EMA. This indicator of complete susceptibility has been retained as a primary indicator to follow up, the evolution regarding AMR and as an indicator for measuring progress made in implementing action plans against AMR. And the corresponding indicator in the field of antimicrobial consumption in animals is the overall sales of veterinary antimicrobials. So we have seen that, at least illustrating through the chakra analysis, that we can show a relationship between the level of consumption and the level of resistance, or the level of susceptibility. It's another way to consider resistance, and in particular to consider resistance, considering as well all the phenomenon of co-resistance. And what we can see, if we consider trends in antimicrobial resistance, and this is a graph taken from the 2017 report, so it's a trends on resistance to limited number of substances in indicator E. coli from fattening pigs. What we can see, if we consider in particular tetracyclines, which is in red in the graph, is that for a number of member states, we observe clearly decreasing trends, which are statistically significant. And here we can quote primarily the Netherlands, but as well France, Belgium, or Austria. And we truly believe that this is related with the stringent policy already implemented by those member states in regarding reduction of use of antimicrobials in food-producing animals and in particular in pigs. Conversely, what we can see on this graph, although it doesn't cover all the member states, but only those member states which have implemented already in the past stringent monitoring of AMR, is that we can observe still increasing trends. So actions are still needed, of course. What we can say as well is that in addition to the EU summary report, or the ESVAC report, there are a number of very interesting national reports considering together resistance and consumption of antimicrobials. And here we can quote the report provided by the Netherlands, or issued by the Netherlands, MARAN, or the report issued by France, by Agence Nationale du Médicament Vétérinaire, at ANSES, Austria as well as a report. And so it's very interesting to consider as well the experience of those member states in their effort to tackle antimicrobial resistance in animals, and as well implementing stringent policy in reduction of antimicrobials. So what we can say here is that the current decision, which goes up to 2020, is going to be reviewed. And EFSA has received a mandate from the European Commission to reassess the technical specifications underpinning the technical requirements of the decision. And we should produce a report by end of March. So this report should be should be published in April 2019, so normally next month. And the idea is to review those technical specifications considering the recent trends in AMR, as well the data collection need, so all the difficulties that the member states may have encountered in implementing the program of AMR monitoring, and as well considering scientific developments. And here the idea is to consider whether it would be possible in the near future to start implementing, most likely on a voluntary basis, whole genome sequencing to complement the phenotypic monitoring of resistance. Alors, this review as well is performed within the framework of the EU action plan of the Commission, the last one, June 2017, and as well it accounts for the outcomes of some audits performed by the European Commission in 14 member states, considering the implementation of the decision on harmonized monitoring of AMR. As well, EFSA works on a number of communication tools. Here we can exemplify the data visualization tool developed by our colleagues from EFSA Communication in order to show interesting results on AMR in food-producing animals and food. What is important to say as well regarding the AMR and the control of the AMR is that, of course, you have most likely a primary factor, which is the use of antimicrobials, but on the vet side, on the veterinary public health side, we should recall as well the importance of the implementation of other legislation, in particular the regulation on the control of salmonella in food-producing animals, in poultry in particular, as well as the implementation of the regulation on the microbiological criteria for foodstuffs. Thank you very much.
Thank you very much, Per-Alexandre. And just before you leave the podium, I just wondered if there were any questions that members of the audience would like to put to Per-Alexandre about that fascinating presentation on the resistance patterns in European animals. Marit.
Thank you very much. Thank you for your presentation. My question is not actually for you, but it's for you. How many, is any one of your countries already implementing this harmonized monitoring of AMR as per EFSA recommendations? Okay. Romania, obviously. Any others? So then I would like to ask, if I may, another question. That do you have the intersectoral committee on AMR? Do you ever discuss these issues, your findings, with your colleagues from the human side?
Thanks. We just started this last year with it. We still collect all information, and we plan to inform other sector, human sector, about this in the next period, and also present on the public our results.
Thank you very much. I'm sure that we will come back to this and during the day and in the interactive session in the afternoon. Thank you very much.
Thank you, Marit. Are there any other points people would like to make right now? In that case, let's move on to the surveillance of veterinary antibiotic consumption. And our next speaker is Kari Garva. She is the chair of the European Surveillance of Veterinary Antibiotic Consumption Sales Expert Advisory Group. And she's also, for a long time, a scientist at the Norwegian Veterinary Institute, and she's going to give us an overview of the SVAC.
Sorry, I have a flu, so if I'm going, I'm sorry for that. And thank you for the introduction, and thank you for being invited here on behalf of EMA. You know, there is a Brexit, so they are extremely busy in terms of moving to the Netherlands these days. So that then I have the privilege to be here to present this project. A little bit about my background, because in 2009 I was engaged by EMA in order to set up the SVAC system. And the terms of reference from the Commission was as simple as that: collect the data, but make it harmonized across countries. And that was, so the project was developed and implemented then across a few years. Then now it's 30 EU and EEA countries that participate. For you to know, it's already mentioned, but actually it's a pretty new legislation on veterinary medicinal products published. And because up to now it has not been mandatory for the member states to provide the data on consumption or sales to EMA, while in a few years it will be mandatory for all the countries to not only provide sales data, but also data on use by animal species. And it's a great volume of data that has to be in the future to be sent to EMA. First with the same species that Pierre-Alexandre told about, where you collect data on AMR, but then it will be extended to other food-producing species, and later on to all other species, companion animal, or it reads even animal kept. So it's really wide in terms of what data to be collected. But there will be developed delegating act as it reads here. But it's future. But I think it's good for you to know that that this will come. The most important thing, I think, in order to set up system, whether it's regional or globally or nationally, is to involve the stakeholders from the first moment. So everybody knows what's going on, so they don't suspect you to do something and they don't know. It creates a lot of trust. And also, of course, to have a national protocol, even though there is an EU protocol or EMA protocol for this. And also to have a template for your collection of data at national level, although there is a template for EMA that you have to use in the future. Because they also have web-based delivery of the data. And also how you collect the data for the animal population. And those protocols you can find, I have put in the kind of icons for these protocols for sales and animal population data there, so you can find it. Making it practical, this. With regard to the numerator for SVAC sales data, because the sales data, it's collected in a number of packages sold for each product presentation. And these are then calculated in a harmonized manner in order to get to express it in weight of substance. So the numerator is weight of active substance, because when you have data for all type of species, it's different defined daily doses, so that cannot be used unless you have data by animal species and you have a DDD animal available. So, and the data are stratified in order to obtain estimates for all food-producing species, very simple by actually excluding tablets because they are, due to the packet state and everything, they are used primarily in dogs and cats. So then you get a rough estimate. This is used for food-producing animals, and at the EU level, horses are included as food-producing species. And then, with regard to the denominator, a proxy for the animal population was developed as a first step in the ESVAC project. And you can read about that also in the first report if you are interested. This concept has been widely exported also to other countries. For example, Canada use it, other countries use it at national. I use it myself in our national report in order to have some comparison with the EU level. So the indicator, very simple, but we thought it was very simple until someone came to us, can't you give the formula? It's so obvious for you, but it's not obvious for us. So I present it here just also to indicate or to mention that sometimes when we communicate such projects, and we have been in the business for some years, then it's easy to forget that you have started once and didn't know this. And I think, so I learned a lot from people outside, from the field, about how to communicate so we understand what you are doing or what you are presenting. What are the deliverables by ESVAC? It's the annual report, and it's also an interactive database where you can go and look at the data. So here they are, and you can access it through that link that is provided on the bottom of this slide. So some data about or some discussion about the use of the sales data. I would say the primary object in the beginning of doing anything, or before doing any actions on use or try to implement prudent use, you need to have data. Before, how can you else evaluate what has been done? So it's purely documenting the situation. And if all countries in the world actually could document the situation, having valid data, that would be a huge step forward. And also here you see the sales data for 2016, and also then I think Pierre-Alexandre, he showed these slides earlier, and you can see here, that it's kind of a south-north or north-south gradient here in terms of consumption and then susceptibility. So what else can you use the sales data for? Because it's aggregated data, it's used, it's used for all species. So it's difficult to find out very precisely what are the action I took in terms of improving use in pigs. Has this worked? But you can at least look at over time to see the overall use. And there has been considerable reduction of sales in some countries, as shown previously in the graph, or Charles showed in 25 countries there has been a 20% reduction from 2011 to 2016. And it's obvious when you have this huge reduction in some countries, there is a potential for reduction in the other countries as well. So I think those data is a driving force for those with higher use than the others to improve their practice. It's also to identify the sales of last resort antibiotics in human medicine. In the ESVAC, the last report, also here you can see a huge difference between these use. And it can be explained by a lot of factors like differences in animal population, what products do you have on the market. But I don't think it's a top secret that prescribing is also habits. It's what you learn in the vet school and a lot of things, prices, etc. Also to compare across sectors. Comparison is a driver for improvement. I think I can state that it really drives it forward because you want to be lower on the scale. So in the IACRA report that has already been mentioned, in one of the chapters there is provided a comparison between human and animal sectors, and then the consumption in the food producing sector is animal sector is overall higher than in human sector, but there are also considerable variations between the human and animal sector. Thank you, and I would like to acknowledge Christine Ignat and Jody Torren at EMA because they kindly supported this presentation, but also I should have a slide, of course, of all those persons that send data to EMA every year, so this report can be presented and I can be here. Thank you.
Thank you very much, Kari. Are there any questions from participants about these consumption data, or indeed about any of the other points which were mentioned in Kari's presentation? I've got one, if I can, from the chair, and that's so that you mentioned the new rules that will apply to member states who will have to provide additional data to the European Medicines Agency. And you said there's going to be lots of new work and analyses, therefore. Could you give us a flavour on what we may be able to look at in the future compared to now? Is it possible, is it simply a matter of having more comprehensive information from all countries, or is there going to be any fresh insights or fresh analyses that you think we might be looking forward to in the future to help it?
I can only refer to what the legislation says about a stepwise approach. Sales data, I'm almost sure that they will continue to be collected because they also will be important in order to validate data collected at farm level by species. So that will continue, and then in 2 years from 2022, data of other species, by species, those that are collected, AMR data are collected for, like pigs, poultry, laying hens, bovine below 1 year, and turkey, did I mention? Yeah, will be collected. And then 2 years, I think, after this, then all data for all other food-producing animals will be collected, and then next step will then be companion animal, etc. So whether they will collect all data for in the end within 8 years or so, whether they will collect data for all species every year and present it in a report, it looks it's huge. Now I think that there will be, this is just reflection, and I have some contacts with EMA on this, that similar as for the others, there need to be developed protocols because and maybe they can have some common protocols for farm level data, but the production system are also so different. So I don't know. I only know that it will be a huge piece of work in the future, and that will require a lot of resources. And actually, may I ask a question when we talk about this to EFSA? Because your legislation, you will have new legislation in 2021, and then that one will last in 5 years, or you will usually?
A priori 5 years, but this is up to the Commission and the Member States to agree about the
Yeah. So within that time, then there will be more data on consumption per species. So so that because then you would, in case you continue with the same species and EMA or according to the legislation, have much more species, then you will have you will have more data about consumption than at EU level than you have AMR data. I'm not sure whether you have reflected on this or discussed this, or whether this at all should be subject for discussion here. But I just reflected on this. Thank you.
Thank you, Gary. Yes, of course, it needs further thought. On the other hand, if I'm not mistaken, you were mentioning, monitoring of consumption in dogs, cats, and all the. And I think there is, because there is no legal basis to monitor AMR in companion animals, dogs and cats, because the legislation derives from food. For what we are doing. So yes, it was a further thinking and discussion with the Commission.
Thank you.
Thank you very much. Are there any other points? Yes, please, Danilo from World Health Organization.
Thank you very much. First of all, thank you, Kai. For those of you who do not know me, my name is Danilo Loverwong. I'm the Program Manager for AMR at the WHO Regional Office for Europe, and I would like to take up Marit's good example of trying to also activate you and get you part of this discussion. The work that you've been showing is extremely important, and it's been a true example also globally. And as far as I know, the World Organization for Animal Health has adopted your methodology and is trying to gather similar data from around the world. Now, you've only shown data, rightfully so, of EU and EEA countries. So my question to everybody here is, have you been approached by the OIE, and have you been invited to start to collect similar data on veterinary consumption of antimicrobials? Yes? Anybody like to share that experience?
Hello, my name is Tatiana, I'm from Serbia. I just want to ask the same question because we sent data about the use and the sales to IE for 3 past years. So I don't know, is this SVAC database open for third countries, and how it's correlated with OIE database about this consumption?
If I understood your question right, is whether you can send data to EMA. Yeah. I was discussing this with EMA before I came here, and we agreed that we should refer to them in order to ask them, because but wait a couple of, maybe even a couple of months before you approach them, because they are now in the middle of moving to the Netherlands. They are extremely busy. But she will be, Christine Ignate, that is now coordinating this project. She was very happy to if you approach her and discuss it.
Any other countries that are working with OIE on veterinary consumption data? Yes.
Macedonia also sent a report about consumption of veterinary drugs to OIE, maybe last 4 or 5 years. Nationally, not.
Before Romel Velev, Macedonia, before 5 years, 6 years, we sent one article for consumption of, not for consumption, but in this article we speak about what is the registration procedure in Macedonia and what kind of antibiotic is registered in Macedonia. We have not till this data, we have not data about how is consumption, but about registration of veterinary drugs, we make our investigation in which kind of antibiotic is more in use in our country. And we send this article, and we are in communication with Jordi about this. They send us the report every year. Thank you.
Yes.
Thank you, everybody. Also, Albania have been part of AGSR project in 2018. There was a communication, let's say there was a good communication between animal part and human part for collecting data and sharing data related to the AMR. Thank you.
Thank you very much. Any other examples? Yes?
Thank you very much. My name is Vesna Dakovic and I'm Director of Administration for Food Safety, Veterinary and Phytosanitary Affairs of Montenegro. This year, first time, actually Montenegro collects data for OIE and also together with our Institute for Public Health collect data as sent to other organizations which sent our request for this data. So from the beginning of this year, we are doing together and send data according to our possibility. Why I said this? Because in Montenegro, only data that we can send in this moment is data for wholesales. So we only have, for veterinary medicine, I just said for veterinary medicine, because now in Montenegro we have 6 wholesales, and from them we collect data for antibiotic use in Montenegro. So that is the situation in Montenegro, but I hope next year we will have quality, more quality data for collecting. Thank you.
Thank you very much. And I'd just like to add that there's nothing wrong with having wholesales data. Many countries only have it on the human side as well. So it's a very good beginning. But the other step, of course, is beyond collecting data is to take action upon it and to maybe do some analysis on, are we using critically important antimicrobials that we should be reserving for human medicine. Does anybody do any additional analysis on the data? Oh, okay. We'll leave it at that.
I hope you've got some, thank you very much, Danilo, and I hope you've got the answer to your question. I think we did get some very good input there. So just before we move on to the last presentation before coffee, this is actually related to the next presentation, Danilo, because I was just wondering, from behind your question, I understood that you wanted to emphasize, one, the point about the importance of the use of the data at national level, not just about providing it to an international organization. But could I also ask, are you able to share anything about what WHO's plans are for working together with OIE in terms of producing any European analyses of the AMR situation with human and veterinary data?
There we are. It's a very good question. At this point, for the European region, we have no concrete plans. But as you may have heard, on the global level, we are strengthening the tripartite, the FAO, OIE, and WHO, with the tripartite plus, and also including the UN Environmental Protection Agency, UNEP. And of course, right now we are in the phase of really trying to get countries to collect data, but it makes a lot of sense to also follow the good example of the European region to start looking at this data collectively. Thank you.
Thank you very much. So that leads us into our last presentation of this session. We've heard individually from ECDC, from EFSA, and on behalf of the European Medicines Agency about the various systems for surveillance of resistance and consumption in humans and animals. But now it gives me great pleasure to welcome Dominic Monet from ECDC. Dominic's the head of the Antimicrobial Resistance and Healthcare Associated Infection Disease Programme at ECDC, and he's a very close partner working with me on AMR, and he's going to talk about the joint activities of the three agencies, which will put how these data put together can show us insights about both what's happened and also about the way forward. Dominic.
Thank you very much, Charles. So now that you've seen all these presentations, you're wondering, so how do we make sense of all this? And that's the purpose of this small presentation, how we do work together, ECDC, EFSA, and EMA, on antimicrobial resistance. And I will make this presentation, and I'm working at ECDC, but I'm making this presentation also on behalf of the colleagues at EFSA and EMA. So you've seen all the networks. Actually, you've seen all minus one. At ECDC, we have EARSnet, we have ESACnet that you've seen, but we also have data on antimicrobial resistance in clinical salmonella infection and Campylobacter infection. And these are presented together with the data from the monitoring from EFSA is doing in one report. And then we have the data on SVAC, on antimicrobial consumption in animals. So every year in February, and this is happening today, ECDC and EFSA published together what we call the European Summary Report on Antimicrobial Resistance in zoonotic and indicator bacteria from humans, animals, and food. The report from 2017 should be published today at the time I'm speaking. So it's One Health monitoring of antimicrobial resistance in foodborne bacteria. So the focus is primarily Salmonella of various types and the Campylobacter. It's a joint report since 2010, and it's based on the legal decision of monitoring for food and animals, and for public health, for human isolates, there's a voluntary agreement of member states. For the purpose of coordinations, there is a meeting every 2 years where we have the colleagues that are in charge of monitoring antimicrobial resistance in Salmonella and Campylobacter infection from human, what we call Food WD net, and then the Food Safety Laboratory Network for Antimicrobial Resistance. As for all these networks, there's an external quality assessment scheme that covers both human and veterinary medicine to make sure that the results are comparable. You already saw results presented by EFSA. I wanted to show you that there are similar now trends of antimicrobial resistance here in Salmonella typhimurium infections from humans. And we see that the trends are going in the proper direction, decreasing in some member states, although we cannot yet make full sense of why it is decreasing. But it's the first time that after many years we can really see something changing. If you want to look at these data in a different way, there is an interactive database that is hosted at EFSA where you can pick the humans or food animals, or various species of food animals. You pick the bacterium, you pick the antibiotics, and you can see resistance presented this way. This is the database for 2016. I suppose that at the moment I speak, it's been updated for 2017 data. So a few years ago, the European Commission actually made a request to the three agencies and said, can can you make sense of all this data, not that we have data? The purpose was to provide an integrated analysis of the relationships between antimicrobial consumption in human and veterinary medicine and the occurrence of antimicrobial resistance in bacteria from humans and food-producing animals. That was a challenge because first we have different systems, we have different cultures, we present data in a different way, so we first had to understand each other, understand the type of data that we had, and we managed in January 2015 to produce a first report. And after all, we were critical about the first reports. We tried to do better in July 2017, and we had a second report with our attempt to do modeling of the existing data. And that's what I will show you. And now we're already working on something that we expect will be better with the hope to have, or the objective to have a report by December 2020. But we think we will do better in terms of presenting the data. So the analyses are performed on the data that we have, the data from these 5 networks. And the goal is to assess the relationships between antimicrobial consumption and antimicrobial resistance, and to be able to provide some conclusions and recommendations in a One Health perspective. So these are the data that we have, and the relationship that we would like to analyze. Keep in mind that we're analyzing aggregated data, although we have data per isolate on antimicrobial resistance, on cases. For antimicrobial consumption, we only have sales data, so we have aggregated data per country. And the JACRA report has the objective of analyzing all these relationships between antimicrobial consumption in animals and what would be the consequence on the levels of antimicrobial resistance in bacteria from animals, antimicrobial consumption in humans, and what would be the consequences in terms of the levels of antimicrobial resistance in bacteria from humans, and hopefully the link between all this, because we're doing all this so we have less antimicrobial resistance in infections in humans, ultimately. That's our goal. The first attempt, or first thing that we tried to do, as shown by ESVAC, was can we really compare the levels of antimicrobial consumption in animals and in humans? On one side, we have milligrams per PCU. On the other side, we have DDDs per 1,000 inhabitants per day. And after reflections together with ESVAC, we said, well, the PCUs, they are kilograms of slaughtered meat. Why don't we calculate kilograms of living humans? Try to find a way to stratify that the small ones weigh on average less and the adults weigh more, and then there are different, an average weight for each group. So we ended up calculating antimicrobial consumption in the second JACRA report in milligram antibiotics per kilogram biomass. Biomass of slaughtered animals, biomass of living humans. And what we found out is we actually use about the same, somewhere between 100 and 150 milligram per kilogram biomass in humans and animals. But there's a large variation between countries, about tenfold between the country that uses the less antimicrobial in animals and the country that uses the most, and 3- to 4-fold difference when it comes for humans. There's a small group of countries on the left that uses much more antibiotics in animals than in humans. There's a group of countries in the middle that once you control for the biomass, use about the same level of antibiotics in animals and in humans. And then you have all those countries that have managed to control antibiotic use to a certain extent in animals and are by now using much more antibiotics in humans than in animals. Then we try to analyze the relationships, and I will start with a simple example, fluoroquinolone consumption and its effect on fluoroquinolone resistance in salmonella infections. And you see on this graph that the level of fluoroquinolone consumption in animals influences the level of resistance to fluoroquinolones in salmonella isolates from food animals, but it's also, as a consequence, on the level of fluoroquinolone resistance in salmonella infections in humans in the member states. There's nothing surprising. We're talking about salmonella, we're talking about a foodborne pathogen, and we know where it comes from. Fluoroquinolone consumption in humans has no influence, as per the modeling and all the data that we had, on the level of fluoroquinolone resistant in salmonella infections in humans. And we have in the report that I encourage you to read similar models for example, Campylobacter infection. When we move to Escherichia coli, and we take again fluoroquinolone consumption in animals and in humans, and fluoroquinolone-resistant E. coli from animals and E. coli infections in humans. So we see that the level of fluoroquinolone consumption in food animals influences fluoroquinolone resistance in E. coli from animals. Fluoroquinolone consumption in humans influences the level of fluoroquinolone resistance in E. coli from humans, but we're missing that link here. So for us, it's the One Health pathogen. We're all responsible, and we should probably at one point divide this consumption between hospitals and community and try to see which one influences most the levels of resistance here. But that means we all have a responsibility here. I will not present to you the results of carbapenem consumption and its influence on carbapenem resistance in Klebsiella pneumoniae. This is obviously a problem for human medicine and for hospitals. Carbapenems are not authorized for use in food animals, and carbapenems are IV medicine that are rarely used to treat patients in the community. But you will find these results also in the report. So at one point with the development of a European One Health Action Plan, the Commission asked the agencies to work together on a joint scientific opinion to develop indicators that could be used for the different sector to provide an overall indication of a situation on antimicrobial consumption, on antimicrobial resistance at national level. In other words, I turn the question to you. Among all these data, what are the one I should follow? What are the one that give me the most information to follow whether the national policy, the national action plan actually has an impact? So this was published in October 2017. The European Commission wanted us to work in a One Health perspective to get a maximum of 15 indicators that we divided in what we call 4 primary indicators and 11 secondary indicators. And they should be suitable to estimate the progress made by reducing antimicrobial resistance to key antimicrobials. They should be robust, whatever that means, take into account a One Health approach, and so we can compare improvements. The second step of requirement was for antimicrobial resistance. We should provide names of bacterial species, define the population where the indicator applies, the antimicrobials to which those bacteria are resistant, provide a protocol and a reporting unit. And for antimicrobial consumption, decide which antimicrobial groups should be looked at, for animals in which production sector, and for humans, whether it's the community, the hospital, or both, and again, provide a reporting unit. There were 2 final points. First, the Commission wanted us to use existing data. So data from the already existing 5 networks that I mentioned, and then that and that's what I think defines the robustness of the indicators, they should be valid for 5 years. We should not have a doubt on some of the indicators and the methodology would change and then the indicator would not be valid and we could not follow trends. So this is a summary of where the indicators were placed. And I will pick an example here. So for resistance in bacteria in humans, the primary indicators are the percentage of MRSA, of methicillin Staphylococcus aureus isolates among all Staphylococcus, Staphylococcus isolates, and the proportion or percentage of E. coli invasive isolates that are resistant to third-generation cephalosporins. And then we have secondary indicators, and for animals, the primary indicator is the one that was just presented by EFSA, that is the percentage of E. coli from food animals that are fully susceptible to all antimicrobial tested as part of the EU monitoring. So what is, when we were doing this, we said, well, we tried to reply to the question from the Commission, and we know what we've been able to achieve, but we also know what are the limitations, and I wanted to review those with you. So one value for us is we're not inventing a new surveillance system. It's based on what we have. It summarizes the situation of antimicrobial resistance, of antimicrobial consumption in human and in food animals. And it's made available to the EU member states to measure their progress. We envision that the next step could be that the member state will use the indicators and start defining targets. So this has happened for antimicrobial consumption after the indicators were produced, but we don't have a follow-up on where member states are with these targets. The limitations, well, it's only 4 major indicators, right, and 15 total. So we try to summarize, and we lose some of the detailed information, which means that when the member states want to follow one intervention that may have an impact in one single sector and possibly on one type of bacterium, then the summary indicators will not work unless we're lucky. They would need to have a specific indicator for that intervention. And that's what is summarized at the bottom. We have an indicator that is MRSA. Well, if the major intervention is in hospitals and has to do with healthcare-associated infections and improving infection control practices, targeting MRSA, that is screening patients and isolating patients, then the indicator would work. But if you pick another bacterium, that would not work. So what are our next steps now? Well, we have started already putting these indicators, if they were not as part of our reports, so we put them as part of our reports, and that's what we did for antimicrobial consumption in humans, for example, in ISACNet. We need to ensure that our data improve, but also that we maintain the monitoring for the indicators. We're not changing now, and what we should move towards is a trend analysis, and then we'll have all this and we'll be able to follow the indicators as part of a JACRA report. In the meantime, things are not stopping. We have several requests from the European Commission to provide joint scientific advice or scientific opinions. That is, one agency takes the lead on the scientific opinion and invites the 2 other agencies to contribute. And at ECDC, we systematically invite our colleagues from EFSA and sometimes EMA to provide advice on our risk assessment. Thank you very much.
Thank you very much indeed, Dominic. And I think what you're seeing there is how integrating these data not only makes the case stronger and stronger for the One Health approach, also enables you to see where in Europe, in this case, there's an association between action in a particular sector and progress in the indicators, and also where that therefore enables member states to do similar analyses, whether they are already part of this network or whether they are part of the CESA network and other networks which are starting to use the same data. We've got the prospect now of being able to make a stronger and stronger and a clearer links between how the problem is being created on the one hand and how the problem is being solved on the other. So thank you very much, Dominic, for giving us those insights. Are there any particular questions just before we break for coffee? Any last question, please, from Norway?
There you go. Just a small question. When you draw these connections between what we find in animals and what we find in humans, how do you deal with the fact that we actually do not have the same definitions of what is resistance in animal and human isolates? As on the veterinary side, they rely on acquis, whereas the clinical breakpoints may or may not be close to the acquis.
We're working closely with UCAST. And actually also UCAS is working closely with CLSI and the Transatlantic Task Force on Antimicrobial Resistance. I think that the small discrepancies are between ECOFs and clinical breakpoints for those bacteria under surveillance are becoming solved one after the other. We've had meetings with the two networks and indicated biannual meetings, and we have discussion there. And I think we're at one, there may be a few instances where we have one dilution difference, but that's all. When it comes to CLSI, and I don't know if in your countries you're still following the CLSI standards for interpretation, we made the decision within EARSnet that we will not, from next year, not accept data that are produced with interpretation with CLSI breakpoints. Since UCAST and interpretation with UCAST is part of the EU definitions, then that should be followed for surveillance. So back to your question, I think we may still have a few discrepancies, but we're getting away from that.
Thank you very much, Dominic. And I think we'll take this as a last question here from the table in the middle. So.
Thank you for a very nice presentation. My question is related to influence of imported foods on antimicrobial resistance. How we consider that data when we consider at national level, like Denmark has low level of consumption antimicrobials in animals, but probably Denmark is not a big country with a lot producing animals, but probably it import food from Spain, where is the high consumption of antimicrobials in agriculture and veterinary medicine. How can we consider this influence?
The fact, I mean, we're still missing a lot of information on infections in returning travelers. So if we look at the network at ECDC, there's a variable that says, is it acquired is the salmonella infection has been acquired in the country or is it imported? So we would need a better compliance, I would say, or better willingness of member states to fill this variable, and that would certainly help us. When it comes to sampling food, I will leave it to EFSA, but there are also issues about getting this information.
Thank you, Dominic. Yeah, maybe here there are two aspects. First, regarding the animals, if you want to compare data on consumption and data on resistance, of course, for monitoring resistance in food-producing animals, we monitor in domestically produced animals. And when you assess the quantities of antimicrobials consumed or used, you consider the quantities domestically as well consumed. And we consider, and we perform some correction in order to account for those animals, you know, slaughtered within a country, but raised in another one, because they have not been exposed to the quantities of antimicrobials used in this country. But